Okay, so we've talked about active range of motion, passive range of motion, gentle overpressure. The last part is the resisted range of motion. Usually done in a slightly shortened position. We try to isolate to one joint. Okay, so if you're testing, the elbow, one arm is going to go, so elbow flexion. One hand is, that you're using to test is going to go on the forearm. The other is going to go on the back of the arm. Okay, not like on the hand and the shoulder, which in case it would bring other joints into that test. We try to isolate to one joint. Try not to cover the muscle you're testing. So you have to kind of practice this, and you just sort of know where your hands will go, but you try not to put your hand on top of the muscle that you're testing. And again, we're going to ask about symptoms. Is there any pain? Okay, you're going to be asking that a lot during the exam. So about muscle testing, there's a whole textbook on muscle testing. This one by Kendall is sort of a go-to resource. A lot of people use this textbook. So if you want more information about testing, it goes into testing each individual muscle, each individual muscle in the thumb or the finger or the extremity. So very good book. It also talks about other things like posture and just how muscles function and coordination. So very good textbook to look at. But when we do resisted range of motion, usually we're testing the muscle, okay? And is it able to do a strong contraction, and is there any pain with that? Is usually what we're looking for. These are generally isometric tests, so we're not trying to overpower the person. We want to see how much force can they generate without moving the joint. And you need to hold it at least 5 seconds. Okay, so sometimes we can, the initial contraction is strong, but if you hold it for 5 seconds, the strength sort of gives out. So make sure it's 5 seconds. I know on the videos that go along with this course, when I go through different regions, it's not always 5 seconds. So make sure you hold it for 5 seconds. So that's quite a long time. And whenever you do these tests, we're going to do it bilaterally, and we're going to grade them. And the grading is out of 5. So this is a table from McGee, right? Still the first chapter. And 0 to 5. 0, there's no contraction at all. The joint doesn't move, the muscle doesn't activate. And so that would be 0. We don't normally see that in an ambulatory setting, but that's just what 0 means. 5 implies complete range of motion, although we're usually just testing isometrically in one position, but it does imply full range of motion against gravity and against maximal resistance. Okay, so that's normal. That's what we would expect. A 4, so complete range of motion against gravity with a moderate resistance. Okay, so there's good strength there, but not as strong as it should be. And sometimes we see, 4 plus, 5 minus, if you're sort of, you think it's sort of in between there. Sometimes we do see those numbers, although that's not on this table. 3 is fair, so a complete range of motion against gravity. So if they can hold it up against gravity, they get at least a 3. Okay, and if you push it down, they get like a 4. If they can hold it maximally, then they get a 5. Okay, and so in class, when we're practicing, you will see some of your classmates getting 3s, 4s, 5s. So when you do these resisted range of motion, get a sense how strong are they and what's normal. Okay. 2, complete range of motion with gravity eliminated. So usually then they're lying down and they're moving the joint, but they can't actually hold that joint or the body part against gravity. Okay, 1 is you can see contraction, but the joint doesn't actually move. Okay, so you need to know these different grades and be able to apply that. Okay, so that's page 39 in McGee. So if we see weakness, if they're getting a 4 or less, some things to think about. Why is that? So pain. So because of the injury, they aren't contracting as strong as they could, or if the muscle that you're actually testing is injured, or the tendon. Obviously, then the muscle will inhibit its own contraction because it tries to protect itself from further injury. If the innervation to that muscle is compromised, obviously then that would cause weakness. If there's upper motor neuron lesion, Okay, so even though you might see increased tone, when you actually test the muscle, it's weaker. And there's sometimes psychological effects. So, and if they're anxious, they're, very stressed, or whatever, different psychological reasons might come into play here. So some things to think about. So if it tests strong, so 4 or 5 out of 5, and there's no pain, so normal, that would be considered normal, okay, especially if they're 5 out of 5. Sorry. Okay, so 5 out of 5, no pain, that would be normal. Okay, if there's pain, but they're still pretty strong, like 4 or 5, maybe 3, 4, 5, it could be a tearing of the muscle, so a first-degree strain, maybe second degree, but again, that would be more painful. Okay, but then also you would see that if you stretch the muscle as well. Okay, so that passive range of motion. If we see any weakness, sometimes that is because of the inhibition of the muscle from the pain. Okay, so the nervous system is just not activating the muscle because there's pain in the area. If we see weakness, so depending on the level of weakness, but if we see weakness and no pain, so it could be a ruptured tendon. So look for tendon defect. Can you feel the spot where the tendon should be, but it's not there? So the Achilles tendon, it could probably be swollen, but you can't actually feel the tendon in there. Look for the muscle bulge. So if the biceps tears, right, there'll be a ball of muscle up at the proximal arm. Consider a nerve root injury. So check the myotomes and check other muscles associated with that nerve root and that muscle. Check the dermatome for that nerve root. Or again, consider upper motor neuron lesion. Okay, spinal cord, brain, or lower motor neuron lesion, which if it wasn't a nerve root, it would be a peripheral nerve. Okay. If there's a lot of weakness and lots of pain, then that suggests it's more of a severe injury, so possibly fracture. Just a note on third-degree strains, right? So when the muscle, the tendon is totally ruptured, it's in 2 pieces. So then often it's not very painful because when you do the muscle test, right, that muscle is not connected to anything, so it's not being pulled on. So then it doesn't hurt, okay? But if there's other tissues torn as well in that area, well, those would hurt. Okay, so just keep that in mind, that a third-degree strain, we often expect that there's no pain, but there are other things that could be painful. Also, other things could provide some sort of, residual strength. So if I tear my bicep, I still have brachialis, brachioradialis, those would resist and cause forearm flexion, even though the bicep might not be intact. Okay, so just be aware of that, right? If I fully rupture my Achilles tendon and my gastrocnemius, my soleus aren't attached to the heel anymore, I still have other plantar flexors in the leg, tibialis posterior, the toe flexors, right? They can actually help me point my foot, plantar flex my foot, even if the gastrocnemius and soleus aren't working. Often for these third-degree strains, there's pain at the time of injury, and then there's less pain or reduced ache. And again, we see that defect where the tendon should be, that deformity because the muscle is bunched up. Sometimes they're more, if there's pain in all motion, so that might be caused by fatigue in the area, or again, emotional hypersensitivity or emotional problems affecting our testing. So that brings us to this idea of selective tension. So comparing active, passive, and resistor range of motion can kind of tell us, is this passive connective tissue, like the ligament or capsule? Is it the muscle? This stuff is very interesting. I actually quite find this very interesting when we're examining an injury. It's very helpful to know your anatomy. So, for example, so here's my elbow, here's the humerus, here's the ulna radius. So let's pretend that there's a sprain here, the anterior elbow. So if I have them actively, extend the forearm, that's going to stretch that tear, and that's going to be very painful. Okay. If they go this way, it probably won't hurt very much at all, right? Because we're not putting any tension on it. If anything, we're putting slack in it. It might actually feel better. And now, when I do passive range of motion, and me as the examiner, I'm watching the person's face, seeing if things are hurt, because I don't want to tear it more. But I'm getting them to relax, and I'm extending. Again, that's going to stretch that tear. That's going to be painful. However, when I test the strength of the area, strength of flexion, and I have them resist as I push down, well, that's contracting the muscle, but it's not putting any tension on that injury. So that might not hurt at all in that shortened position. Okay, so pain on active, pain with passive, no pain with resisted range of motion. That tells me that this is probably a ligament injury or a joint capsule injury. However, if it's the muscle itself or the tendon or the attachment of the muscle, then when they do active range of motion, okay, so that would actually stretch the muscle, so that might hurt. If they do active the other way, that would put tension on the muscle, so that might hurt. When I do passive, so me as the examiner doing all the work, that probably wouldn't hurt. But if I stretch that muscle, that tendon, the muscle attachment, that would hurt. And then when I do resisted range of motion, and they put tension in that muscle, then that would hurt. Okay? So that's sort of a difference between the ligaments and the tendons. And then when we look at joints, so we can do active and passive range of motion, but if you actually put compression into the joint, so let's say I have a sprain in my wrist, if I actually push and put compression in the joint itself, well, that's not going to affect the ligament sprain. But if there was a joint dysfunction, pushing in there, a little bit of movement, that actually might hurt. Okay? Whereas if I put traction, right, that separates the joint surfaces and now do that movement, that would probably not hurt or hurt significantly less. But a ligament sprain, though, that might stretch it and that might hurt. Okay, so looking at the comparisons of when you have pain under different, tension situations, range of motion, active, passive, or resisted, or this compression, contraction, can tell you. Is this a ligament injury? Is this a muscle injury? Is this a joint injury? Okay, so you should know that, and it helps you sort of pin down your diagnosis. There are lots of orthopedic tests that we'll do in this class. McGee is all, like hundreds and hundreds of pages of orthopedic tests. We're not going to do all of them, right? And you wouldn't want to do all of them in your exam. So based on your history, based on your examination so far, you choose ones that are, going to tell you the most information, going to confirm your diagnosis, or rule out others on your diagnostic list. Okay? So use selectively based on the rest of the history, or based on the rest of the exam, based on your history. It's important that the person's relaxed. Okay, so the purpose of these tests is to compress or to stretch certain tissues, but if they're tense, then it's putting a lot of tension and maybe compression into tissues that we don't want to for this test. Okay, these tests, like I said, are trying to stretch things that are maybe injured, so that might cause more pain, that might cause apprehension, that might make things worse, might cause fractures. So you need to be aware of that. You need to be careful. You need to let your patient know to give them informed consent, and then also know to tell you if there is pain. And again, it's helpful to start on the uninjured side first, so that they know what you're doing. A neurologic test, so we're going to do a lot of dermatome, myotome testing, that kind of thing, reflexes. Sometimes you can skip a neurologic test if from the history this seems like a very straightforward injury. If you want to ask them, is there any numbness? Is there any weakness? Heaviness. Sometimes they don't see something as weak, but it feels heavy when they move their leg, for example. So if they have none of that, maybe you just do a quick screen, but don't have to do a full involved neurologic test. So sometimes it can be very quick. But if you are doing a test, explain to them what you're doing, why you're doing it. Okay. and also what you want them to do. Okay, you know, do you want them to tell you if there's any pain? Okay, those kinds of things. So there's dermatomes. We're going to be spending a lot of time on dermatomes in this course. Remember that there are the peripheral nerves are the actual, you know, the nerves that supply the muscles and the skin for sensation. So it could be a problem at the nerve root and affecting the dermatome. It could be a problem with the peripheral nerve affecting that area. Myotomes, okay, so right, the nerve roots supply certain muscles very specifically, so testing those muscles can kind of tell you if that nerve root is affected. Again, the peripheral nerves, you want to consider those, not overlook those. So I have an example of that in a slide coming up. Deep tendon reflexes, we do a lot of that. We're testing nerve roots. There are superficial reflexes, so the abdominal reflex, the cremasteric reflex. You know, babies have that rooting reflex. So those are all superficial reflexes that you can use to test the nervous system. And then there are pathological reflexes. So, you know, the most common example is like on the bottom of the foot, right? And you use sort of a blunt instrument to stroke the bottom of the foot. The plantar reflex, we call that. Okay, and so very important for upper motor neuron lesions. And there are other tests, you know, Babinski's test and those kinds of things, testing cerebellar function. We don't talk a lot about that in this course, but sometimes that's important to do. When we do reflexes, we're going to grade them. When I went to school, it was always like 1 plus 2 plus 3 plus. McGee seems to not use those pluses, so you might see that. So just be aware of that. That's normal for a lot of people when they grade deep tendon reflexes. So a 0 is no reflex at all, okay? And sometimes that's normal for people. If you do see that, you want to do the Gen-Jurassic maneuver to sort of distract, you know, their concentration and check the reflex. 2 is normal, so you know, if we see the response that we would expect, that would be normal. If it's less than what we expect, that's hyporeflexia. That's a diminished response, and that would be a grade of 1. People do not sort of grade in between these, so they don't say 2 minus or 1 plus. It's either a 2 or it's a 1. If it's exaggerated, you know, a brisk reflex, and sometimes that's normal for people, but that would be a 3. And then very brisk or clonus, which is abnormal. Both of those would be abnormal. That would be a 4. Okay. For those of you that don't know, so you know, part of this reflex is you're stretching the Golgi tendon organ in the tendon of the muscle. Right, in that sense, is one synapse reflex up the spinal cord back, and that's that twitch, right? The activation of the motor nerve, and we get that twitch. With clonus, that twitch is enough to actually stimulate the whole reflex again, and so you see this sort of beat type of motion. And we see that with upper motor neuron lesions, so things like strokes. So that's abnormal. Yeah, you know, I mean, I've seen people who've had a stroke and they can walk, you know, with difficulty, and then sometimes, you know, their knee starts sort of twitching and, you know, grabbing onto the knee to try to hold it still. That's clonus. Okay, so be aware of that. That's always a 4 on our neurologic test, on our dependent reflex. So I mentioned you need to be able to differentiate between problems in the nerve root and problems in the peripheral nerve. So just to kind of explain that. So here's our spine and here's nerve root. Okay, so remember the nerve roots, they come out and they form a nerve plexus, and then usually then those go on to form the peripheral nerves, right? And certain nerves will innervate certain muscles and innervate certain areas of the skin. And sometimes when you trace back that muscle, it's mostly innervated by one nerve root. So for example, biceps is mostly innervated by C5, C6, okay? But actually, if you look, that muscle probably actually also has some innervation by other nerve roots, the one above, the one below, and it's not just purely one level, okay? but all of those nerve roots, they go through the plexus and they form that peripheral nerve. That nerve, whether those axons come from this level or this level or this level, they all go through that peripheral nerve and innervate that muscle, right? And so when I want to move it, the signal comes down, activates a lot of neurons here, but some in here, and they activate that muscle. So, so an example here, the musculocutaneous nerve of the brachial plexus, its motor function it innervates a lot of the forearm flexors, right? So biceps brachialis. So if I have an injury to my musculocutaneous nerve, I will have weakness in those muscles. I'll have weakness in forearm flexion. But the sensory portion of the musculocutaneous nerve is the lateral arm, right? So if I have an injury to my musculocutaneous nerve, I have weakness in forearm flexion, and then I have hyposensitivity or numbness in my lateral arm. Okay, so that's a very specific pattern. However, if I have injury in my C5 nerve root, well, the myotome for C5 is largely the biceps, so you'll see weakness again for forearm flexion. However, the C5 nerve root, the sensory fibers innervate mostly the lateral upper arm. So, if it's a problem with the C5 nerve root, I'm not going to see weakness here, or sorry, numbness here. I'm going to see numbness up here in addition to the weakness. Okay, so testing those things, I can see, oh, this is probably more likely a problem with the musculocutaneous nerve and not the C5 nerve root, or this is more a problem with the C5 nerve root and not the sort of peripheral nerve. Okay? So obviously more than one thing can be injured. You know, if you get C6, this is the dermatome for C6. But if it's just one level, then you'll see a very different pattern. Okay, so you have to be able to tease that out. Where are the areas of numbness, and is that related more to a dermatome, or is that related more to a peripheral nerve? Where are the areas of weakness? Is that more related to a nerve root level, or again a peripheral nerve? Okay, when you do sensory testing, again, it's very important to give your instructions. Sometimes we just do a quick screen, so my instructions here, I'm going to run my hand over your shoulders, so let me know if you feel a different side to side, okay? And it's a screen, they could probably keep their eyes open. Usually I like to have them close their eyes. I think people are more in tune with what they feel. And you know, I want them to tell me not what they see, but what it is they feel. And so, you know, the shoulders, make sure you get the shoulders, their arm, the back of the arm, the forearm, the front, the back, you know, get the surfaces of the hands. And so that's very quick, okay? And that's my general scan. But if I suspect that there is a neurologic deficit, then I'm going to do more detailed testing, so things like dermatomes. And I'm going to use either cotton, so this picture here, that's a piece of cotton, or brush. So this is one of my reflex hammers, and in the handle it has a little brush, and so I'm going to use that and have the patient tell me, you know, with their eyes closed, where they feel it, and they point to where they feel the brushing. So that would be for light touch. Or if I want to test superficial pain, you can use a pin, or again, this reflex hammer, very cool, very useful. There's a pin in there, or I can use a pinwheel. So in chiropractic college, we used the pinwheel. This is a Wartenberg pinwheel. There's a picture of it in the slide there. I like these a lot. So there's a little impression there. That's where my fingers go. And so that's sort of the balance, so that every time I use this, I always get the same amount of pressure because I'm using the gravity, the weight of the pinwheel. So if I do an exam today and I do it a year from now, I get the same amount of pressure, so it's very reproducible. But you need to show people that and what you're going to do with it. I'm just going to go very lightly, and I might show them either, let's say if I'm going to examine the upper extremity, show them on their knee, this is what it feels like. Or, you know, if you can do lower extremity, you got to show them, you know, on their hand. You always pull, you never push, right? You don't want to dig into the skin. And then we go through, you know, the different dermatomes with that pinwheel. Okay, so Wartenberg pinwheel, very useful. And then we're going to do either light touch or superficial pain for the dermatomes or the peripheral nerves. depending on what we suspect the injury is. Okay, there are other tests, so you can do test temperature. So I guess the classic example is like if you had test tubes, glass test tubes, or I guess it could be plastic test tubes, and you fill it with water, one with hot water, one with cold water, and you just put it on the skin, okay? And you have them tell you, is this hot, is it cold? Vibration, we can use tuning forks. So this is 128 hertz tuning fork. If I get it going, it's not that loud, right? So you don't want the person to really hear it, but it's vibrating, okay? You have to get good at getting reproducible vibration either time, so either tap it the same way or kind of pinch it, okay? And you would get it going. Of course, you explain all this ahead of time, but you're going to place it on the skin, on a bony prominence. They tell you, if their eyes are closed, they tell you when they feel it, and then when the vibration stops. So you have to be able to stop it without changing the pressure on the surface. And then you start with a bony prominence. Okay, and if they can't feel it distally, then you have to go to something more proximal. If they can't feel it, you have to go to something more proximal. Okay, so vibration. And if you know your anatomy, it can be very useful. So here's the spinal cord, here's the anterior, here's the posterior. Of course, it's not this big in real life. Like even in the cervical spine, it's only about the size of your finger, and that's where it's largest. Okay, that's the spinal cord largest. But here on the person's right side, okay, so here's because it's the posterior. These are the sensory fibers. Here's the cell bodies in the dorsal ganglion. Excuse me. So here in the posterior column of the spinal cord, this is the fasciculus cunatus, this dorsal column. The nerve fibers for position, so proprioception and vibration and fine touch, right? They come through here, so they're on the same side, go up, and then in the level of the brainstem, they cross over to the other side, right? So things I sense here are processed up here. Okay, but if we look at, for example, crude touch, so those fibers, they come across and they cross the midline of the spinal cord at the level where they come in, and they come up on the contralateral side. Pain and temperature in the lateral spinal thalamic tract, which is over here. Again, they cross at the level and then go up through the brainstem, to the thalamus, and then to the cortex to be processed, to be actually sensed. So, for example, if I have a spinal cord injury on this side in my neck, then at that level, and that level I might get a loss of precision sense and vibration. But then on the contralateral side, distal to that, I lose my sensation for pain and temperature and crude touch. Okay, because they cross to that side. Sorry, they cross from the lower extremity, they cross to this side, and they're in that level of the spinal cord. Testing proprioception, so this tests the joint receptors, the receptors in the skin, the muscle spindles. Those things again go through that dorsal column on the ipsilateral side. The way we do that is, if you're going to test a finger or a toe, you don't want to use the anterior posterior aspect, because you can feel pressure on them. You actually have to hold it from the side, and you show the person, I'm going to move it up and down, and I'm going to end either in the up position or the down position. So you tell me if you feel it up or if you feel it down, and so you have them close their eyes, and then you move it. Okay, what do you feel? Oh, it's up. And you move it, and oh, it's up. And you move it. No, it's down. Okay, so they have good position sense. They have good proprioception. So that's sort of how you test that. So moving along to palpation, again, often this is later in the assessment because it can cause a lot of pain, and then everything after it can be painful, which then, we lose our sensitivity of our exam. But it's very useful if you can if they tell you it's right here and you find, oh yeah, that's painful and you can feel it swollen, then it really helps to determine what is the injured structure when you can feel it. Again, we're going to do bilaterally, and we're going to start on the uninjured side. And you want to be systematic. Okay, so you don't want to palpate one thing and palpate something else and palpate something else and come back to it. So I'm going to start on the uninjured side. I'm going to start proximally and work distally to where the injury is. And I'm going to start on the other side, proximally and distally. Palpate adjacent structures. See, is there a large area of sensitivity around the injured structure? Start lightly, okay, because sometimes these things are very painful. Okay, if there's a fracture and you go right to the fracture, that's going to make him jump. That's going to really hurt. So start far from the injury and work your way towards it. Start lightly. So you want to get a sense of what does the tissue itself feel like. Is there spasm in there? Is there fluid in there? Get a sense of the muscles and palpate the muscle belly. What is the tone like? If it's flaccid, there's totally no tone. That's abnormal. Is there increased muscle tone there? Spasticity is often actually more of a response to movement. And you might even see, when you do passive range of motion, how fast you do it. If there's more tone when you do it quickly than when you do it slowly. And it's often in sort of one direction, whereas rigidity is, if things are tight and it doesn't matter how fast or slow or what direction, there's increased muscle tone there. When you're palpating, are there fibrous bands in there? And again, compared to the uninjured side, how thick are things? So as things become fibrotic, they tend to get thicker. So you have, like a chronic tendonitis in the Achilles tendon. It's often really thick. Okay, how does it feel? Is it really stiff? Is it rigid? Is it soft? How does that compare to the uninjured side? Identify if there is swelling. If there's swelling and there's blood, it's often very gel-like, right? And that's usually, in the first couple hours because blood bleeding into the area is rather quick. Whereas if it's just sort of inflammation, it takes a little longer for that fluid to accumulate, but you feel things are softer, things are sort of boggy, spongy, right? Because it's fluid-filled and not congealing like blood would. Okay? So get a sense of what it is you feel. And then if you do find a lump or a lesion, then you want to make note of it. And you want to note where it is. Okay, so often we will use, some sort of obvious landmark and measure from it. So, that's, 3 centimeters from the the radial styloid process on the left side. Okay, and so make note of that. How big is the lesion? Okay, is it half centimeter? Is it 5 centimeters? I mean, that's very different. Okay, so make sure you know how big it is. What is the shape? Is it round? Is it oval? Does it have an irregular shape? It's L-shaped. Those kinds of things. Is it mobile? Can you move it? Or is it stuck to the tissue underneath? What is the density or the texture like? Is it hard? Is it soft? Is it firm? Is it rubbery? Okay, is it boggy? So like a cyst would be boggy because it's fluid filled. Is it rubbery, like a lipoma? Okay, so some students in the class might have lipomas. If you feel the lower back, you might find these sort of oval, kind of firm, rubbery, bodies in the subcutaneous tissue. Okay, what are the borders like? So can you feel where the lump begins and ends, or is it hard to figure out where does it begin, where does it end in relation to the rest of the normal tissue? Okay, and then is it tender? Does it hurt when I press on it? So it's good to note all of these. Okay, 7 different things to note. So the last few slides are looking at nerve injuries. So we often talk about upper motor neuron lesions, lower motor neuron lesions. So here is the cervical vertebra, and here's the spinal cord in the cervical spine. So if it's an injury in the spinal cord or higher, and it's affecting motor function, then that would be an upper motor neuron lesion. Okay, at the level of the injury, you might see lower motor neuron signs. right? So like here, this is the anterior, right? These motor neurons, the cell body is right in here in the anterior horn. So if those are injured, you would see a lower motor neuron lesion signs, but then everything below this level would have upper motor neuron lesion signs and symptoms. Okay? If the injury is to the nerve rootlet, the nerve root, or if it's in the plexus where these neurons are sort of reorganizing, or in the discrete peripheral nerves, then those would have lower motor neuron signs. Okay? So how do you differentiate them? And so in class, I would put this up and have you fill out this table. What is the tone? What is the effect on the deep tendon reflexes? What do you see with pathological reflexes, and what is weakness like for lower motor neurons, and what are they like for upper motor neurons? So again, if you want to pause this video, see if you can fill out this chart. But here are the answers. Okay, so we see with tone, we see flaccid hypotonicity, right? So loose, limp muscles. But for upper motor neuron lesions, there's an increase in tonicity. Okay, you know, that spastic sort of posture. For deep tendon reflexes, along with this hypotonicity, we see reduced or absent reflexes. Okay, so we're doing our reflexes, and it's reduced compared to the uninjured side. But eventually we see with upper motor neuron lesions, there's that increased reflexia, or sometimes even the clonus. With pathological reflexes, so again, we're doing our plantar reflex, stroking the bottom of the foot. Okay, so whether it's a lumbar injury or if it's a cervical injury, we do this, and for lower motor neuron lesions, it should be a normal response. So that plantar reflex, when we stroke the bottom of the foot, most people, they sort of withdraw or they sort of flex the toes. That's normal. But for that Babinski response, you stroke the bottom of the foot and the toes, they kind of splay out. That's normal in a newborn infant, but it's abnormal in a child and an adult. So that would be a positive, okay, and suggestive of an upper motor neuron lesion. Okay, so it could be in the neck, could be in the brainstem, could be in the cortex. And then weakness, we see weakness in both cases, but for the lower motor neuron lesion, it's just at those levels. So if it's the nerve root, it's just at that sort of myotome level, or if it's the peripheral nerve, it's just at all those muscles innervated by that peripheral nerve. If it's in the spinal cord, the brain, then it's all of that levels, all those levels and below. We see weakness, okay, multiple levels. Okay, so we should be able to differentiate between upper motor neuron lesions and lower motor neuron lesions. And then I mentioned about differentiating between nerve roots and peripheral nerves, and sort of what we see with the organization of which neurons innervate which muscles. So because of that, we see sort of a difference in the onset of symptoms. So for nerve root injuries, again, this nerve root might mainly innervate a certain muscle, but there are some motor nerves from this level and from this level also innervating that muscle. So we see weakness, but it's not as profound. We see muscle wasting, atrophy, but it's not as profound. But if you injure that nerve root, if you injure that peripheral nerve, and it doesn't matter whether those axons came from this level or this level or this level, they are all affected. And so you see more of a neurologic deficit to that muscle. So the weakness, the onset is faster, and the wasting is much faster, right? Within a month, you see significant muscle wasting. Okay, so that kind of is another thing that sort of helps suggest, is it a nerve root, is it a peripheral nerve? In both cases, we will have lower motor neuron signs, so reduced tone, reduced reflexes, okay, no pathological reflexes. The other thing to be aware of is sometimes for these nerve root or peripheral nerve injuries, there's this idea of a double crush injury in effect. So, for example, for carpal tunnel syndrome, there might be compression here, but I might not actually have symptoms. But then as I get degeneration, in my cervical spine, there's impingement of the nerve roots here, impingement of the median nerve here, and sometimes that's enough that now I get my carpal tunnel syndrome, and that's because it's just that one side is not enough. But once you get nerve compression at multiple sites, now those nerves are affected. And so that idea is called double crush. And so then maybe I need to treat both sites. Okay, or it could be multiple sites. Okay, but just be aware of that. Okay, so that's the lecture on the general approach to examination for physical medicine. I hope you found this helpful. If you do have any questions about the material, again, please email me. I'll be happy to answer them. Okay, so that's it for now. Thanks.